Hello, everyone. Welcome. New friends, old friends, colleagues, and mentors all. Welcome to this, our 81st episode, shall we say, of MRF HIV SCI ECHO. I am Dr. Gregory Boss. I'll be facilitating today along with Conrad, our coordinator, who is the brains behind the scenes when I'm in front here struggling. So I want to thank everyone for tuning in for this special session and give a special thank you to Professor Collins, who will be presenting our didactic presentation today. I'll just give a brief introduction to Professor Collins. She wears many hats. She is professor both of psychiatry and behavioral sciences at the University of Washington, as well as professor of global health. She's the director of the International Trainings and Education Center for Health, or ITEC, for which we have the Thank For ECHO program, as well as the psychosocial program, many programs over the years at the Medical Research Foundation. She is executive director, of the University of Washington Consortium for Global Mental Health. And prior to her taking up of those duties at the University of Washington, she served as director for Office of Research on Disparities and Global Mental Health at the U.S. National Institute of Mental Health. Her research directions focus primarily on mental health and HIV, as well as adolescent mental health. And she has well over 60 published papers to her credit. So we are tremendously privileged to have her with us today. And Professor Collins, I'll turn the floor over to you to present today's didactic.
Great, thank you so much, Dr. Boyce. It's a real pleasure to be here and a pleasure to see all of you. I'm going to jump right in and share my screen. So I would like to talk today about integrating mental health and HIV services. And I'll start with a question. What is required to successfully identify and treat a mental health condition in the context of HIV care and treatment? This is, I guess the second question is, what, if anything, prevents this from happening? And maybe we can come back to this question at the end of the conversation. I think as a global community, most of us that work in mental health are trying to answer this question. And I know that many people working in HIV increasingly are also trying to answer this question. So I'll start by answering pieces of that question by talking about, first, we need to understand mental health and mental disorders and their consequences. We need to know what barriers and facilitators influence access to treatment, understand the relationship between HIV and mental health, know the reasons for integrating mental health and HIV care, and understand strategies and principles for integrating HIV and mental health services. And we'll go through these in the coming slides. So just a reminder that mental health is the capacity of thought, emotion, and behavior that enables each one of us to realize our own potential in relation to our developmental stage. This is a World Health Organization's definition. Mental disorders, on the other hand, are disturbances of thought, emotion, behavior, relationships that can lead to substantial suffering and functional impairment, very important, in one or more major life activities. We often use the term mental health condition now in place of mental disorder because of stigmatizing associations with the term disorder. So ensuring that language is clear is very important. And I want to just underscore that we don't consider emotional experiences or distress a disorder until there is functional impairment. And what defines a disorder is also influenced by cultural norms. Mental health is increasingly conceptualized along a continuum, from well-being to specific and persistent mental health syndromes. Why is this important? And as you look at this image, you'll see at the very top, we're referring to a continuum that goes, as you move to the right, you see increasing severity of symptoms. And you see that we all fall along this continuum, from well-being and no distress to a defined syndrome that may be that may be chronic and persistent. And typically we move along this continuum. Sometimes we will have nonspecific mental distress. Sometimes that will lead to the need for early treatment as the nonspecific distress coalesces into something that can be diagnosed. But everyone falls along this continuum. And I think this is important for a few reasons. It gives some universality to the way that we talk about mental health problems. During the COVID-19 pandemic, I think more members of our communities moved toward the nonspecific distress and some to defined diagnosable syndromes, especially anxiety and depression. This continuum, or thinking about these conditions in dimensions, is also destigmatizing in some way because there really is no us versus them. Everyone falls along this continuum. And the final thing I want to highlight is that interventions can occur at every stage along this continuum. And that means it's just as important to be thinking about interventions to promote mental health and maintain well-being and no distress as it is to identify interventions to manage severe mental health conditions. And of course, as you can see, interventions can range from getting support from informal networks, self-help, coping strategies, all the way through seeking help from a primary care provider to specialist mental health services. So I'm going to focus for the most part on disorders as we move forward in the presentation. But I want to start by reminding us that 38 million people, give or take, live with HIV around the world. More than 1 billion people worldwide live with a mental or substance use disorder. These are very common conditions. This is about 13% of the global population. And I just put some prevalence data for Trinidad and Tobago. This comes from the Institute for Health Metrics and Evaluation that operates the Global Burden of Disease study. And they have estimates for countries around the world. And if you look at Trinidad and Tobago, you'll see that the color of the bars represent age groups. So the darkest is 15 to 19, then young people 20 to 24, adults, a big swath 25 to 49, older adults from 50 to 69, and then seniors from 70 to 89. If you look at Trinidad and Tobago, just looking at all mental disorders, this is telling us is that in 2019, when these estimates were done, around 18.5% of adolescents were living with an identifiable mental disorder. And you can see that those numbers actually go down as people get older. And Trinidad and Tobago compares quite closely to what the Caribbean in general looks like. And then the next set of bars represent depressive disorders. And you can again see that, in fact, we see some increase across their age groups, and anxiety disorders around the same. People, prevalence of around 4% to 5% for anxiety disorders, depressive disorders around 5 to 6% for the most part, a little bit lower in adolescents. But one of the things I want to highlight is that these conditions, mental health conditions, are non-communicable. When we think of them in terms of disorders, these are non-communicable disorders, and that affect young people much more than others do. So note the high prevalence among young people, and that these then persist across the lifespan. We know that about 50% of mental disorders that are present in adulthood begin by the age of 14. About 75% of those conditions that are present in adulthood begin by the age of 24. So these affect young people, and which makes them somewhat unique from other non-communicable diseases. What are some of the consequences of these conditions? I'm going to talk about mortality for a bit, because I think that's also going to be quite relevant to HIV/AIDS. We know that people with mental disorders have a mortality rate that's twice that of the general population. And in this meta-analysis that Elizabeth Walker did some years ago, she and her colleagues found that all-cause mortality was elevated for people with psychoses, with mood disorders, and anxiety disorders, with psychosis greater than anxiety and depression greater than bipolar disorder. But on average, there was about a 10-year loss of life from all of these causes. And that tends to be related to multiple factors, often perhaps inability to adhere to care, for people with more severe conditions, lack of access to care, something we call diagnostic overshadowing, when a person with a known psychiatric diagnosis comes to care. Often providers don't focus on their medical conditions, but focus on the psychiatric condition. So many of these things together, including sometimes medications that cause side effects that can lead to chronic disease. As a result, there's about a median 10 years of potential life lost. And that means around 8 million deaths per year are attributable to mental disorders, to co-occurring mental disorders. We saw similar issues in COVID, where this is data from 60 million patients in the United States who had a recent diagnosis of a mental illness and had a much greater odds of developing COVID. So people with attention deficit hyperactivity disorder with a 7-fold greater odds of developing COVID, bipolar disorder, similar, depression, 10-fold, schizophrenia, almost 10-fold odds. And the data also showed that people with a diagnosis of a mental disorder had higher rates of hospitalization for COVID as well, nearly twice that of people without a mental illness. So it just goes to show us that when we recognize these conditions, we also need to be sure that we're addressing people's mental health needs and their other medical needs equally attentively. Now, one of the challenges that we see around meeting the needs of people with mental health conditions around the world, these are again global data, is that there are few places in the world where people can get minimally effective treatment for these conditions. And I'll just quickly walk you through this bar chart. So the light blue is showing what is the minimally effective treatment rate in lower, middle, and low-income countries. For anxiety disorders, on the left, major depression and substance use. So only about 2% of people who live in a lower middle-income country get minimally effective care for anxiety, 4% for depression, and around 1% for substance use disorders. But if we go to high-income countries, and Trinidad and Tobago, your high-income country, we're only saying that about 14% of people with anxiety disorders get adequate care. Only about 1 in 5 people with a major depressive disorder, and only 1 in 10 with substance use disorders get adequate care. And why is that? There are other factors related to this that may be causing this are human resources. In some countries, the issue is around actual financing of mental health services. We know that only 2 out of every $3 spent on mental health, well, actually 2 out of every $3 spent on mental health globally goes to running psychiatric hospitals as opposed to care in the community. Only 21% of countries actually are implementing mental health policies and plans that are human rights consistent. Countries on average spend just 2% of their health budgets on mental health. There are, in all countries, typically there is a shortage of mental health workers. That's certainly true in the United States. I imagine that's also true in Trinidad and Tobago. There are a lack of essential medicines in many countries, and resources that can be accessed digitally are often also lacking in many places. But here's just a quick glance at the health worker situation around the world for mental health workers. Again, you see that around 13 mental health workers are available per 100,000 people globally, and huge disparities depending on what the income level is of different countries. One of the innovations that's happened over the last 20 years in mental health globally is to say, well, if we don't have specialists, if we don't have enough psychologists, psychiatrists, social workers who are focused on mental health, perhaps we can identify different cadres of providers to deliver these services. So task sharing or task shifting, which we also do in HIV care, is providing more abbreviated training to a group of people to deliver a certain set of services. So in this case, task sharing could mean that instead of a psychiatrist delivering that service, a primary care nurse delivers an intervention. Instead of a clinical psychologist delivering that service, you could also have a caseworker delivering that service. So over the last 20 years, we've seen a really robust increase in the evidence base that shows that you can train people with more abbreviated training such that they get the skills to deliver evidence-based interventions to manage mental health conditions. We know that that requires good supervision of those people who are being trained, but we have evidence that that works, and it's been tested in many parts of the world, Africa, Asia, Latin America, to name a few. So this helps us to understand, we've seen something about the prevalence of these conditions, that they're very common. We've seen the impact on mortality, and we've seen that, in fact, we have an issue with people getting adequate care, but that one of those problems, which can often be related to human resources, can be addressed with task shifting. So let's talk about integrating services for HIV and mental health. And I'm going to start by reminding us in this somewhat busy slide about why we want to think about these two conditions together. So first, starting at the top, there are shared determinants of mental health conditions and HIV acquisition, right? There's some demographic factors can influence whether you develop a mental health condition, as they can influence whether you develop HIV. We'll look at some of the biological, so having pre-existing illnesses, having an infection can certainly increase your risk for HIV. Pre-existing illnesses can also increase risk for mental health conditions. Maternal health status is an important factor for both HIV acquisition as well as acquisition of development of a mental health condition later in life. Cognitive and behavioral determinants include things like low self-esteem, impulsivity, use of substances, transactional sex, social and environmental determinants, everything from low socioeconomic status, having a lot of life adversity, social marginalization, experiencing stigma and discrimination, experiencing abusive institutionalization. All of these can be shared determinants related to HIV and mental health condition acquisition. And importantly, we know that there is a bi-directional relationship between HIV and mental disorder, such that HIV increases the risk for mental disorder acquisition, and having a pre-existing mental disorder or mental health condition can also increase the risk for HIV acquisition. When you see these two occurring together, we also see that they have chronic disease consequences. There's a public health impact. That means having HIV increases potentially prevalence of mental health conditions, increases the disease burden. When we see both of these together, we see higher mortality with both of these conditions. And we often see unmet need where there's insufficient detection of one or the other, right? People don't know their HIV status, or they haven't been identified as having a mental health condition. There are also social and economic impacts of reduced productivity, impoverishment, and again, unmet needs. On the right hand, though, we can see how we can respond by screening for mental health problems and having a full assessment when the screening is positive. Moving to treatment, psychological and pharmacologic can then lead to decreased risk for other risk behaviors, can also lead to improved adherence to prevention, treatment, and care, as well as linkage and retention and care. So takeaway here is these are highly kind of interrelated, and we can learn how best to manage them together. I just want to focus a bit more on threats to health, psychosocial well-being, and quality of life for people living with HIV, and reminding us that stigma and discrimination that's associated with social identities, behaviors, or legal status is a major contribution to poor quality of life and to mental health challenges. Policies and legislation that criminalize or affect members of key populations, that also can affect people with mental, neurological, or substance use conditions. These can also influence HIV disclosure, exposure, or transmission. Similarly, these policies and legislations can criminalize or affect access to harm reduction and treatment services for substance use conditions. And finally, exposure to violence is another is another threat to health, psychosocial well-being, and quality of life for people both living with or at risk for HIV. So I'm going to focus mostly on depression, but I just want to take a minute to talk about HIV and substance use conditions, again, sharing some global data. An estimated 283 million people are affected by harmful use of alcohol. We know that high-risk alcohol use increases risk of HIV infection. In data from about 6 years ago, it was found that about 3% of AIDS-related deaths were attributable to alcohol. Around 11.3 million people in the world are estimated to inject drugs. And you can see that about 10% of that group, a little more than 10%, live with HIV. So drug use increases risk of HIV transmission, and people with substance use conditions tend to have worse treatment outcomes than those without. And finally, harm reduction and treatment of substance use conditions is associated with effective HIV prevention and increased coverage and adherence to HIV treatment. Okay, so wanted to touch on that. We can come back to substance use later, but wanted to just give some basic information. But I'm going to go back to this bidirectional relationship between HIV and mental disorders. First, reminding you all, I think we often don't think about this population of people with severe mental illnesses are often not often the priority of healthcare systems. And yet, this is a group that tends to be much more vulnerable to HIV infection. And you can see in these, again, this is a review paper that's grouping together several studies across different countries and continents. You can see that the prevalence of HIV among people with severe mental illness is quite elevated in most places, sometimes much higher than the general population, and other settings about equal to the general population. And just to give you a sense of what that looks like, if you take Uganda, for example, the HIV prevalence among women with mental illness is about 14% compared to women in the general population, where it's only around 8%. Botswana HIV study looked at the HIV prevalence among almost 1,000 hospitalized people with mental illnesses, saw that that was 31%. The HIV prevalence among hospitalized women was 53% compared to 38% in women in the general population, and among hospitalized men, much lower. So again, just highlighting that risk among people hospitalized for mental illnesses, but also there's a gender component here, showing the greater vulnerability of women, which is reflected often in population HIV data as well. Depression is probably the most common mental health condition that people with HIV experience. And here are estimates of, as you can see, pretty high prevalence among people with HIV in North America, 30 to 40%. India and China, these are a couple of studies that showed very high rates, around 60%. Sub-Saharan Africa estimates are around 25% in terms of people living with HIV, prevalence of depression. I put Jamaica here because it's in the region, and some recent and some older studies in Jamaica have shown that about 37 to 63% of people with HIV had mild to severe depression in one study. And a more recent study looked at people attending an STI clinic and found that there were, again, pretty high prevalence of depression, a very high prevalence of post-traumatic stress disorder at 44%. And I think perhaps most striking is that about 80% of these folks had no mental health care, and only 7% had mental health care in the past 6 months. So again, huge need, often not access to services. And I'll also remind us that suicide, which is often linked to mental health conditions, is another risk for people living with HIV. About 700,000 people die by suicide annually. Among people living with HIV, this is a recent meta-analysis showed that about 22% experience suicidal ideation. Attempts, around close to 10% of people in this large population of 170,000 individuals from countries around the world. And suicide deaths accounted for about 1.7% of the people in this group. People in prisons, other key populations, have an increased risk of suicide, and we want to be especially attentive to young people who are members of key population groups, where suicidal ideation and suicidal behavior can be elevated as well. Risk factors for suicidal behaviors include not having any treatment, not having any HIV treatment, substance use, depression, low quality of life, living alone, a family history of suicidal behavior, and actually being in a hospital setting, which likely indicates somebody having more severe illness. Risk factors for attempts and suicide are similar: history of depression, family history of suicide, having a mental health condition, and being in a hospital setting. Importantly, targeted strategies to reduce suicide risk, attempts, and deaths benefit people living with, affected by, or at risk of HIV. So the same kinds of interventions we do for other people with at risk for suicide can also be done in this population. Depression, as you could see, was a risk for suicide, and other predictors of depression among people living with HIV include being female, older age, unemployment, negative life events, a history of childhood trauma, having a greater number of HIV-related physical symptoms, low CD4 counts, other impaired function, and poor social support. And of course, I think all of you are aware that consequences of depression and HIV include poor uptake of HIV testing, poor adherence to care, greater attrition from care, and of course, higher mortality. Depression has also been associated with increased sexual risk behaviors. I'm just going to touch on the mortality link between depression and HIV outcomes with a US sample of nearly 6,000 adults, which showed that for every 25% increase in the percentage of days that you live with depression, they found a 19% increase in risk of mortality. So really there's a cumulative risk of living with depression and mortality in the context of HIV. We did a similar analysis of data from 4 African countries and found a similar outcome. This is a cohort study with about 2,500 people. Our group, the majority of the participants were women, and about 60% of the sample, 57% were virally suppressed, and about 18% had possible depression by the assessment tool. And we found that again, in this group, every 25% increase in the percentage of days lived with depression was associated with a 69% increase in the risk of all-cause mortality. So again, just I think more impetus for ensuring that we recognize and manage depression in the context of any chronic disease, but HIV specifically. I wanted to just highlight a study that talked about HIV needs, changes in HIV needs in Trinidad and Tobago. This is from a little while ago, but this was an analysis of data that was collected by from the National AIDS Hotline. And the researchers examined the open-ended comments that the people managing the calls were taking. They analyzed this, of course, confidential data, anonymous data. And what they showed in these 2 different time periods, from 1998 to 2002, mental health was one of 5 primary topics that people raised when they contacted the AIDS line. And that those topics related to mental health included wanting information about mental health symptoms when living with HIV, bereavement, marital problems, sexual problems and concerns. And then 5 years later, or 5 to 10 years later, in 2007, they did a follow-up and saw that mental health remained one of 4 primary topics, and coping with relationship concerns were one of the main set of mental health topics. Partner violence after testing positive was part of this, violence when addressing infidelity, but simply managing the relationship as well in the context of HIV. So in summary, why integrate mental health care? The prevalence and burden of mental health conditions is high. Mental health and physical health problems are interwoven, and co-occurring mental health conditions increase morbidity and mortality. The treatment gap for mental health conditions is very large, meaning that few people that have these conditions get minimally effective treatment. Primary care for mental health enhances access. And when I say primary care, I mean whether that's primary care, whether that's primary HIV care, can increase access to intervention, and similarly, primary HIV care for mental health can also help to generate good outcomes. Okay, so some essential principles for integrating mental health services are first, that these attend to human rights and access to justice, that these integrated services attend to gender equality, that they take a life course approach, recognizing that people are going to have different needs at different stages of their journey, that they focus on empowering the person who's utilizing services, that they take a multi-sectoral approach. We've talked about some of the social risks associated with HIV that also can influence people's mental health and well-being. So being able to ensure that people are linked not just to the medical services, but to other services in other sectors, whether that's justice, housing, social services. And these need to be people-centered services, and of course, quality services. For these reasons, we've seen, I think that recognizing how important this is, we've seen a steady global push for integrating mental health into HIV care. UNAIDS in 2018 hosted a thematic segment. That's the conference that they have at the end of the year with the program coordinating board, focused on mental health and HIV. In the interim, they released the 2025 HIV targets, which actually emphasize that 90% of people living with HIV and people at risk are linked to integrated health services. Equally, they set targets actually emphasizing the need to reduce inequalities, which are drivers of HIV infection, but also drivers of poor mental health. Last May of 2022, I worked with UNAIDS to produce the manual called Integration of Mental Health and HIV Interventions, Key Considerations, which was launched to give some real guidelines to how one can go about doing this sort of integration. We also know that universal health coverage supports integrated care. Services are integrated and focused on the needs of people and communities in a universal health coverage setting. And it also involves reorienting health services to ensure that care is provided in the most appropriate setting with the right balance between out and inpatient care and strengthening the coordination of care. So coming back to the issue around, well, how do we make this happen in the community, often in communities where we don't have adequate numbers of mental health care providers? There's also a growing evidence base to show that task shifting for delivering mental health services is effective for interventions for people living with HIV. And most of these are psychotherapies that have been delivered by lay health workers or peers. And many of these examples here come from African countries, from Uganda, from Zimbabwe. A more recent trial in Tanzania looked at psychological group intervention for perinatal women. So the good news is that we have a strong evidence base for task shifting, but we still have much to learn about the sustainable implementation of these interventions. And this last one actually is one of the few studies of combining an adherence intervention that's led by peers with problem-solving therapy for adolescents that was successful in reducing symptoms of depression and anxiety, and the peer intervention has also been successful in reducing viral load. All right, so I'm gonna talk briefly about integrating services from the structure of care. So integrating HIV care requires considering the structure of care. Where is integration going to happen? Will it happen through co-locating services that you go to one clinic and you get HIV care and you get depression care or other counseling and therapy in the same clinic? Or will it happen through different provider networks? So that maybe you go to HIV care, but then there's another partnering part of the hospital or part of the clinic where you have an easy referral for care, or will some service delivery systems fully integrate services? So this is just reminding us that we can have these different levels, starting with clinical and community or integration at level 1. And this is an example on the right side of, what does having an integrated care using a care manager in one clinic, what could that look like? Level 2 might be having professional integration or organizational integration, and level 3 is integration of service delivery systems. So all of those are possibilities. But as we think about strategies, and I'm going to shift to talking about strategies for integrating care, the first question is what to integrate. What are we actually trying to integrate? And we want to start with conditions that are commonly occurring in HIV settings: depression, anxiety, trauma, and depending on the setting, it may be management of alcohol use disorders, or there may be other substance use disorders in a given setting. And treatments for all of these include both psychological therapies and medications. Psychological interventions, of course, can be delivered by non-specialists if needed with adequate support. And here is a set of evidence-based psychological interventions that the World Health Organization's Mental Health Gap Action Program recommends. So behavioral activation, relaxation training, problem-solving treatment, cognitive behavioral therapy. I'm not going to go through all of these, but these are interventions that can be delivered in the context of HIV. And the field, the mental health community, has worked to adapt many of these interventions into what we call scalable psychological interventions that can be delivered by providers with abbreviated training. And these interventions have typically been modified to simplify their implementation while maintaining the active components that make the intervention work. So we can talk more about that. You might ask, I just saw this long list of therapies. How do we know? Do these treatments really work across cultural settings? Well, the evidence says yes. We've seen lots of studies coming from many different places around the world showing that these interventions can work. But what we don't understand as easily, and what has surprisingly not been as explored in this context, is broadly whether the same explanatory models of depression that originated when these therapies were first formed are also the same explanatory models of depression in the countries where they're now being implemented. And so this is a study in South Africa that tried to understand one type of therapy, which are cognitive behavioral therapies, which are probably amongst the most effective type of therapy. So they recognize that cognitive behavioral therapies show effectiveness across cultures. But they said, what are the cognitive and behavioral constructs that are most important for understanding and treating depression among people living with HIV in South Africa? This is a South African study. And what they found was that in the context of depression, the cognitive construct that was most common was rumination, or thinking too much. The behavioral construct had to do with lack of energy and the need to be lack of energy, lack of motivation. And what they found briefly in this study were that two elements of cognitive behavioral therapy, behavioral activation is one of those, were associated with reduction of depressive symptoms, improved quality of life, and reduced functional impairment. And so this was an important study because, first of all, it found that, yes, the cognitive constructs, the experiences of depression that people are having in this cultural setting actually match quite well with the elements of the treatment that are being introduced. But the takeaway is that behavioral activation in particular might be a particular treatment value in this particular context. And we've certainly found that behavioral activation is a helpful intervention in many cultural contexts for people with depression. I'm going to talk briefly about just checking the time, about another review of psychological interventions for people living with HIV that Ethel Nakamuli and Pungu published just a couple of years ago. And this is a study that examined these different evidence-based interventions: cognitive behavioral therapy-based interventions, problem-solving therapy, psychosocial support groups, mindfulness-based interventions, rational emotive behavior therapy for alcohol use, and brief alcohol interventions. They looked at studies that utilized these specific therapies to try and understand what they could learn about their effectiveness among people living with HIV. And these are the kinds of questions they asked. Do provider qualifications matter? Does it matter what the delivery approach is, whether it's an individual treatment or a group treatment? What about the caseload per provider? How important are the number of treatment sessions? How important is adherence to those treatment sessions? And what are the active ingredients of these psychological interventions that are most important? So what they found as they looked at this large group of studies was that significant intervention effects were associated with the caseload. Actually, providers who had a lower caseload for delivering psychological interventions were more likely to, this was associated with better outcomes. That's not terribly surprising. The approach used, whether it's group therapy or individual therapy, and the provider qualifications, whether it was a specialist or a lay health worker, actually were not associated with effectiveness in this sample. Adherence to treatment was associated with significant treatment effects, but that didn't actually attain statistical significance. What they also learned was about active ingredients. And what they learned was that if you look at the active ingredients that are highlighted in purple here, in this list of treatments, there were many different active ingredients, from relaxation to meditation to psychoeducation, but the ones in purple, venting, which is really expressing your personal problems, social support, coping skills, cognitive restructuring, behavioral activation, were strongly associated with intervention effectiveness, and actually having more than 3 of these in one intervention was also associated with intervention effectiveness. So grouping these active ingredients together, and many of these are captured in interventions like cognitive behavioral therapy, for example. Okay, so now we've talked about what to integrate, treating common mental health conditions in HIV and using psychological interventions as one avenue. And then how do you do these? How do you integrate? Well, if we start with planning, one has to first assess the goals and functions and the resources of the HIV program that's going to receive mental health services, right? Or begin to implement mental health services. And this planning phase means being really clear on what are the existing knowledge and skills of the healthcare providers. Can they identify common mental health problems? Do they actually know when to refer? Are they motivated to build new skills in this area? How do they perceive the benefits of these skills? And do providers view these skills as helpful for their primary responsibilities, not just for new responsibilities? Planning also includes identifying shared and achievable objectives. So linking with mental health system, right? The mental health service providers, conducting joint assessment of needs and the feasibility of integration, identifying the specific tasks for healthcare workers. This is very important, right? What exactly is each person's role in integration? And then specifying the training, support, and supervision for clinicians to provide services. So assigning responsibilities is the next piece of planning, and establishing a monitoring mechanism. Assigning responsibilities to healthcare providers, as well as to managers of the HIV program and to the mental health team that will be helping to deliver services. Then we move on to preparation. What is the preparation that's required? Again, specifying the tasks and the human resources. So the MHGAP intervention guide describes how to deliver evidence-based care for mental, neurological, and substance use disorders, and that's an incredible resource. But then managers in a given clinical setting have to decide, well, which providers are going to develop which skill sets in order to deliver the elements of these interventions and manage a range of mental health problems. So again, continuing to think about tasks and human resources, one has to specify the skill sets for the available human resources and decide who's going to carry out these tasks. And I know that the psychosocial working group in Trinidad and Tobago has been working on some of these very questions. So who's going to actually do the screening, engagement, education of patients and family members? Who's going to do the close follow-up and tracking of adherence to a mental health intervention, as well as the clinical outcomes? Identifying the targeted evidence-based psychological interventions is key. Identifying what will the pharmacologic treatment be, if any. what are the population-based outcomes tracking and quality improvement processes, right? How are you going to track, oh, how's that depression, how are those depression symptoms progressing over the next month? And then what is the structure for specialist supervision and consultation? So after preparing, then we begin to provide services, right? And providing services, provision of services can happen in facilities that are coordinated and holistic, managing both physical and mental health care. Ideally, you want to use a multi-level approach that provides integrated interventions and focuses as well on meeting the needs of people's, of the broader social determinants of health. So not only are we meeting your psychological needs, but also providing access to other needs, housing needs, work needs. Social support and stigma reduction, of course, are important elements of integrating care. And then the final piece of the integration planning is monitoring and evaluating. And that means developing and applying a framework for monitoring and evaluation of progress and outcomes. And in order for these to go to scale, to move beyond a pilot project, for example, we have to standardize an integrated care package, and that can be scaled. In some of the evidence-based models for integrated mental health care, there are models that exist. The collaborative care model is the most researched example, which we can talk about if people have questions about that. But also effective development and implementation of integrated care requires ongoing iterative adaptation, right? You keep learning each time you implement this, you're monitoring what happens and you're learning through iterative adaptation, through testing your hypotheses about what works and what doesn't work, through monitoring the performance data, and then of course making improvements accordingly. Okay, so I'm gonna switch gears because we've been talking mostly about integrating treatment for HIV and mental health conditions. And I want to just say a few words about HIV prevention and mental health integration, and then I'll wrap up. So what do we know about the relationship between mental health and HIV prevention or risk behaviors? And what do we know about interventions that address mental health in the context of HIV prevention? We did a narrative review of the literature to understand what we could learn about the relationship between mental health related symptoms and HIV prevention behaviors. And this is a super high level summary that overall, in the set of studies that we examined, if you looked at the data on PrEP, depressive symptoms, the more depressive symptoms present were associated with worse adherence to pre-exposure prophylaxis. There were some exceptions, but the data overall went in this direction. Similarly, if the goal is more HIV testing, we saw that more HIV testing overall is associated with fewer mental health related symptoms. Again, there are always some exceptions, but that's the overall direction of the data. And similarly, inconsistent condom use or condom efficacy tends to be associated with more symptoms of depression or PTSD. There are always exceptions, but again, that's the general direction of the data. What works for HIV prevention and improving mental health? Well, at the systems level, amongst the studies that we examined, effective linkages between services were very important. So linking HIV testing to mental health services, to legal and other services. The best example of this was an organization that really was a trusted community organization that supported a robust peer network and through which people could connect to their peers, but then had access to linked services within the community. At the individual level, these data showed that evidence-based psychological interventions, usually using cognitive behavioral approaches, were most effective for addressing mental health symptoms, and these could be integrated into structured HIV risk reduction interventions as well. So such that you both reduced HIV risk behaviors, but also reduced symptoms of trauma or depression that these interventions are addressing. There were some studies on structural interventions that showed promise. So cash transfers were linked to fewer depressive symptoms for boys and delayed sexual debut for boys and girls. So what are some takeaways for integrating HIV and mental health interventions? This is something we all have to do because the global AIDS targets are calling for this, that linkage to mental health services for 90% of people at high risk of HIV. And they're calling for a reduction in punitive laws and policy, stigma and discrimination, gender inequality and violence, other major drivers of poor mental health. So one of the goals that we all need to be working toward is optimizing social interventions that can reduce HIV risk as well as risk for mental health conditions. And here are some of the considerations that we need to address when we're thinking about integrating care. So we have to adapt our interventions so that they are appropriate for the context. And I think the large volume of studies of cognitive behavioral therapy, problem-solving therapy show that these therapies can be delivered in a way that is appropriate for different contexts. We need adequate human resources. In some cases, those human resources may be lay providers who may be more acceptable to some populations than mental health specialists are, depending on where you are. We need to pay attention to the frequency of visits that are needed in the context of HIV care. People may not be able to come weekly, and with new models of care delivery, multi-month dispensing, it may be not reasonable to expect someone to come to a weekly therapy meeting. So what's the frequency of visits needed, and when do you really need to worry about attrition from care? We need to ensure that there are referral pathways for stepped care. People need more intensive care. What are the pathways to referral for that? In the context of using different kinds of providers, some of whom may be new to delivering a mental health intervention, we have to have good methods for ongoing coaching and supervision of people delivering psychosocial interventions and psychological interventions. Medications have to be available when they're needed and accessible and affordable. And ideally, we begin to adapt our health information system so that people's mental health information is a part of that, right? So that when you're entering all of your HIV-related data, you're also entering your data on what is this person's PHQ-9 score, right? What are their depression screening? What is their anxiety screening? What are these scores looking like, so that we can be sure that just as we're following their viral load, we're following their well-being with respect to depression or other common mental disorders. And of course, we need to ensure that as we're integrating all of this, doing all of this work for integration, that we're caring for the emotional support of the providers who are doing the work, because this is hard work, and clinics are busy, and providers are asked to provide a lot and also need care and support. Finally, we have the opportunity when we begin to develop new kinds of care for the community to identify community partners and leaders for co-design of what we're doing. Invite people who are going to be using these services in to think with you about how to co-design, how to deliver them. What are the best ways of linking people for HIV and mental health resources? And then I also want to remind us that opportunities for integration mean opportunities for meeting the needs of the most marginalized people who are at risk of and living with HIV. And I want to also highlight people with serious mental health conditions who, as we mentioned, can be at very high risk for HIV acquisition. And yet this is an area that's often underattended to. So facilitating the integration of sexual health promotion into mental health care settings is a part of that. Resuming the studies that help us to promote sexual health and HIV prevention for people with severe mental illnesses, and recognizing that establishing intimacy and options for consensual sexuality can be a part of a healthy recovery. That's another important. These are steps that can help us to be inclusive in the way that we think about care. And finally, I just want to close by reminding everyone that in May of last year, almost a year ago, we launched the Integration of Mental Health and HIV Interventions, this WHO and UNAIDS document. It's a wonderful document, which you can find online. I'm just going to flash the link here. And actually, I don't think I can put that in the chat. I don't know how to do that. But anyway, that's Googleable online, and it's a wonderful resource for anyone who's exploring these issues. Okay, and I'm going to stop sharing. And I think we have a little bit of time for questions. And I'm going to pause to see if anyone has questions or comments. And I think I see some questions in the chat. So let me just make my chat window large enough so that I can read all of these. Okay. Okay, so to remove the burden on the healthcare system, what about the possibility of self-screening using the same tools or adapted ones and possible interventions like practicing self-care so that people, so that there are people who may not need to see a professional? I would say that that's actually a really nice idea that, in fact, most people do self-care automatically, right? So when there's a minor problem, maybe the first thing that people do is turn to someone close to them, turn to a close person to say, oh, I'm having this problem, I'm stressed, I'm having a challenge. Talk to your social network, right? But I also do think that, and there are tools. This is where digital access comes in handy, right? That there are tools where people can say, oh, I want to screen myself for depression. I can screen myself for this and see, oh, how do I do on a screening assessment? And if yes, if you're kind of mildly depressed, there are actually web-based tools for helping someone to walk through a psychosocial intervention. So that's possible. I don't know how accessible those are to most people. You have to dig for them, and they're not always free. So that's one of the challenges. But those of you, you may have a better sense of what's freely available and readily available to folks that's more self-care related. And I see your hand, Alana.
Yeah, so there's been no talk in the healthcare system about the same way they started with like HIV self-testing and those things. There's been no talk about making tools available to, general public or patients so that, I'm going to take this and I need to see my healthcare provider, or it's okay. These feelings that I have, this tool said it's pretty normal. I'm not, so I'm okay. And the reason I was asking if it was too risky is how objective are people about themselves? Do they, I guess they'd have to be honest with themselves, but then I'm thinking when a healthcare provider asks you the same questions, they have to hope that you're being honest and objective too. So I guess same difference. But as you talked about the burden on the healthcare system and task shifting, etc., I was just wondering if it was possible to have people go through a first line of screening themselves. Although a lot of people probably aren't going to want to admit they need help if the tool did tell them they needed to.
I think we can do a lot more to promote self-care, most likely, to promote self-care, and in that educating people about self-care, educating them about how they can get help and where they can get help if they need it. And I think being clear in that kind of psychoeducation, what are the signs that you might want to talk to somebody else, right? What are the signs that you might want to talk to your doctor or talk to a counselor? What can that look like? So I think that's part of a kind of a psychoeducation approach. Be interested to know if there are others, if what goes on in your environments that kind of helps people navigate their way. I know here where I live, people often have a lot of trouble figuring out how to navigate systems for mental health care, but that may be different elsewhere.
Hi, Dr. Boyce here. So if anyone has any quick questions, because we're rapidly approaching the end of our time together, you can either put your hand up, ask a question, or put something in the chat box. You want to be respectful of Professor Collins as well as everyone else's time.
Lots of information.
Yeah. So let's see any hands. All right. So in the absence of a question, I just want to thank you, Professor Collins. This was such a fabulous presentation.
It looks like we have one quick question from Anna.
Quick question. I put it into the chat, but the demystification of the words mental health, because it's just like with HIV, it's still associated with something negative. So I was just trying to figure out what has been the push, whether international, well, I guess internationally in your case, to sort of make people understand it's a neutral term. It doesn't mean you're crazy, and it doesn't mean it's just a term, mental health. And the same way we've reworded things to change their perception, I'm going to assume mental health is here to stay, those two words.
Yeah.
Nobody's going to rephrase them, right?
Such a great question. And, you know, and mental health should be a positive term, right? Mental health is something that we want. We want to have mental health as opposed to, you know, not being healthy. So it's a great question, Alana. And I agree with you that over time, even the terms mental health, which should signify something positive, have become associated with the stigma that's related to mental illnesses and mental health conditions. We have a long ways to go on destigmatizing, but again, I feel like this is the other, as we talk about integrating, I think the same ways that people are thinking about how do we destigmatize HIV, right? We do it by giving people good quality care, by showing that people can get better. Same thing that we can do with mental health conditions, right? Same principles. And again, a great opportunity for collaboration across these two areas. But thank you, everybody. It's really nice to be here. Thanks for the invitation.
Again, thank you, Professor Collins, for a wonderful presentation. And just I suppose just reflect on you know the ITEC was responsible for the funding our psychosocial program, which came to end in October of last year. And I think even for experienced providers who've been doing this for a long time, you know, it crystallized so sharply how important and how critical addressing these issues in a really intensive, structured, and programmatic way was able to you know, achieve better outcomes for patients and get more patients who were not even in a mental health care system, you know, in care, on meds, stabilized and doing better. So again, this is an opportunity for all of us to think about how we make this a routine thing in part of care. And again, I thank you for your expertise and your experience in giving us some of this information.
Great. Thank you so much. Have a good day.
Thank you. So there's a quick housekeeping notes. Our next session will be on the 11th of May. We're hoping to have Dr. Kwame, who is one of our previous physicians at Mrftt, who is now in the UK doing a postgraduate training in gastroenterology and hepatology, to give us some of our knowledge and some of our training in terms of the management of viral hepatitis. So we hope to see you then. And that's it for me from HIV SCI ECHO. Again, thanks everyone for participation, and it's been a wonderful session. Take care, everyone. Bye.